thanks for coming. I hope everybody learned something from my talk here. Yeah, so we're going to talk about antidepressants and pain, and I picked this. Sometimes it can be very confusing to the patients with chronic pain. Well, isn't this medication usually for depression? Yes, it is. A lot of them are. A lot of the medications we use are used for depression, seizures, anxiety, you name it. But over the years, studies, these medications have been well studied, and multiple studies have shown that these medications actually help with chronic pain. So I put this talk together in an attempt to kind of shed some light on that and go over some of the ways of why we think that these medications work. Okay.
So let me just show you here. I'm going to start sharing again, so it's recording, and then you can just hit next.
Okay, what if I have to go back?
Yeah, arrows. Use arrows.
Okay. So just hit this arrow to go?
Yeah, go forward, and then backward and forward.
Okay. Yeah. All right, so once again, just about me again. I grew up in New Jersey, in the Jersey Shore area. Went to Notre Dame undergrad. Went to the American University of the Caribbean Medical School, which is in St. Martin. Basically, I was there for the first 2 years, kind of the classroom work. The second 2 years, I did clinicals at actually a hospital down in Bakersfield, quite a few out in Connecticut. And then went to Penn State, which is actually in Hershey, Pennsylvania, for a 4-year residency program. Followed then by moving out to Fresno for private practice for the last 13, 14 years. Before coming here as a pain fellow, and I just became interested over the years. I became interested in pain management. A good friend of mine went into it, and he would kind of give me a lot of information on kind of that field, and I was lucky enough to get into this program. So why don't we get started with something real simple? What is pain? One of the simple definitions. So the International Association for Study of Pain, IASP. It's one of the leading pain groups in the world. They study all aspects of pain and have meetings every year, and they've come up with kind of this definition of pain, which is an unpleasant and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now, I underlined emotional because we all feel pain differently, and pain is an individual feeling. What might be we all throw around the numbers, 3 out of 10, 5 out of 10. What might be a 3 out of 10 to somebody might be a 10 out of 10 to me, or what might be a 2 out of 10 to me might be a 5 out of 10 to someone else. The bottom line I wanted to give you with this slide is that everybody's pain experience is different, and which kind of goes along with why antidepressants work in some of these pain diagnoses. And then let's move on to chronic pain. So usually, classically, I've seen chronic pain defined present for over 3 months, over 6 months, over a year. Typically, as a general rule of thumb, I prefer 6 months. I think that's, overall that's much longer than you would figure that you would heal from a surgery or heal from an injury. So that's kind of the. Obviously, it's not the only guideline we use, but 6 months is kind of the guideline I like. So that's chronic pain. Pain, lasting over 3 months, over 6 months, over a year. And that's what we'll be concentrating on today. So this it's a simple nervous system slide. This is basic science. We have the central nervous system. All the central nervous system is the brain and the spinal cord. That's it. Everything else is the peripheral nervous system.
So anytime you think central nervous system, just remember, just brain, spinal cord, that's it, the entire central nervous system. All the other nerves, that goes to all the other parts of our body, peripheral nervous system. All right. So.
All right, so next, how does pain travel? And, hopefully all this can be read. Some of the words on the bottom are a little small, but, the classic picture you see of pain, we hit our finger, we bump our elbow, the pain gets transmitted. It goes from our periphery to our spinal cord. Then it goes up the spinal cord to our brain. And that's where the pain signal kind of gets taken in. And you can see there's generally four parts of the pain transmission of the pain signal. One's transduction, that's the actual site of injury. Transmission to the spinal cord, modulation, we'll go into a little bit more in a bit. Basically, the signal is being transformed in the spinal cord and heading up to the brain where we see perception. And that goes along with what we already talked about a bit. Everybody's perception is different. Everybody's pain experience is different. Everybody's brain is different. That's why everybody's pain experience is different. So just kind of concentrating on perception for a minute, we all react to pain differently. We all have different ideas of pain. And just to expand a little bit more, here's the brain. Don't worry about all the subsections of the brain. What I want you to take out of this slide is the perception. Okay, perceiving pain occurs at the thalamus, with cortex being an important area of discrimination of sensory experiences. Now, once again, don't worry about all that. Just know that perceiving pain is different in all of us. And I just try to illustrate that here with a little bit bigger picture of the brain in different areas. What types of pain are there? Well, basically there's three. There's you have your neuropathic pain, which is pain caused by a lesion to the central nervous system or some type of dysfunction of the nervous system. You've got your post-herpetic neuralgia, you have your neuropathic back pain. The nerve roots are coming out of the spine, are being compressed by arthritic joints in the spine. Distal polyneuropathies, secondary, due to diabetes, HIV, chronic infection. Central post-stroke pain, that may be something that not a lot of you are familiar with. But after a stroke, having chronic pain, neurologic pain coming from the brain and affecting sometimes the entire side of the body. Trigeminal neuralgia, that sharp stabbing pain that comes and goes, or can be around the eye, which is secondary to the trigeminal nerve, which is one of the nerves that supply the face. We have one on each side, trigeminal nerve, trigeminal neuralgia. CRPS, complex regional pain syndrome, which can sometimes happen secondary to an injury, where you can actually see, CRPS of the upper extremity secondary to an injury, which then months later you may find swelling. You may find that you lightly touch the limb and extreme pain. You may get weird growth of clumps of hair in that area, discoloration, numbness. All that's neuropathic pain. When we have our nociceptive pain, we have kind of what I kind of tend to think of as the pain that kind of you can figure out why it happened and why it's happening. You broke your arm, your elbow hurts, arthritis, sickle cell crisis, sports exercise injuries, mechanical low back pain. In this case, not where the nerves are being squeezed as they come out of the spine, but just kind of arthritis in those joints of the back, where you just move a certain way and it's just kind of that back pain that stays right in the middle of the back instead of kind of shooting down the legs. Post-operative pain, we probably all have this. You have an incision, you got to close the incision, right? It's going to hurt. You know, did you have abdominal surgery? You know, surgeon digging down deep into the abdomen, you know, maybe taking out a gallbladder, maybe taking out a part of the colon. It's going to hurt for a while. That's all nociceptive pain, where, and as it says, caused by activity in neural pathways in response to usually damage to the tissue itself instead of the nerve. So nerve pain, tissue pain, neuropathic pain, nociceptive pain. So nociceptive, kind of think tissue, neuropathic, think nerve. And then there's pain that's somewhere in between, you know, both are causing pain. Back pain where it's squeezing on the nerves and you have arthritic joints. So just kind of, you know, just kind of an overview of the types of pain. So here we go. Our friend Bob here. Why antidepressants? I feel good. I feel great. I feel wonderful. I get this question quite a bit in clinic. Okay, we're going to put you on nortriptyline. We're going to put you on Cymbalta. We're going to put you on gabapentin. Well, doctor, you know, aren't some of those medications for depression or anxiety? Well, I guess they are. We're going to talk right now why those medications are good for chronic pain, or when you may think that they're not good for it. Great movie, by the way. What About Bob? I don't know if everybody's seen it, but I highly recommend it. So why antidepressants? I'm gonna try and keep this simple. Multiple studies, and I have some references at the end, some studies I use for this, but multiple studies have shown patients with chronic pain actually have an increased incidence of psychological factors. Top two, we see them: depression, anxiety. Why do they go hand in hand? We don't quite know, but do we become anxious and depressed because of our pain? Does the pain linger? Does it become worse because we have anxiety and depression, or some amount of that already? But yeah, they're very, very interrelated. Lots of things going on in the brain, chronic pain, and you know, you're going to find depression, anxiety stemming from the brain as well. You know, across those two, and they're going to be interlinked quite a bit. That's why you see a very high percentage of patients with coexisting psychological factors in chronic pain. So it continued. So just to expand a little bit more, 1999 study of 9 controlled trials of tricyclic antidepressants, your nortriptyline, your amitriptyline, your dizipramine, treating fibromyalgia. Overall, they found the effect of these medications was moderate relief of pain. Not going from a 7 to a 2, but maybe a 7 to a 4, 7 to a 5. And you know, as you know, 7 to a 4, 7 to a 5 may just be enough to get you back to, a really good level of function, which is actually the top thing that we look for in pain management. We're not necessarily trying to treat patients by what number of pain they have. Well, that's, it's kind of a big guide. The most important thing that we're doing, that we feel, is that we're getting you back to your function. You know what, doctor, I was able to walk for 5 miles almost every day until this pain started. I got a 7 out of 10 pain. I'd really like to get back to that. If I could change one thing, I'd like to get back to being able to walk 5 miles. Okay, you know what? We're going to try some medication. We're going to try some other things. We're going to try to get you back to that. Now, you may not, your pain may not have to be back down to 0 to enjoy those activities again, but let's try to get your pain from a 7 to a 4. Let's try and knock 50% off. Let's try to get from a 6 to a 3, and then get back to some of the things you like doing. So moderate relief of pain, so I can hold off on a tangent there. The biggest effect that they found in this study anyway was the effect on sleep quality. Now, why is that important? Sleep is very, very important. That's, your body's, that's your best chance your body has to heal itself, to grow, to restore function. Very, very important. And sleep quality by itself can bring down your pain levels. Modest effect as well in decreasing areas of tenderness and stiffness. And
Fibromyalgia, you may or may not know. One of the criteria has kind of been, I'll talk about 11 out of 13 tender areas. If you have, at least 11 of these tender areas all over your body, probably have fibromyalgia. Tenderness, stiffness, so that that decreased those areas. Just this is tricyclics, which is actually probably the most studied class of antidepressants. And go into that a little bit more here. Let's see, let's go to major depression. Another big psychological issue, right? In the general population, the incidence of major depression over a lifetime, 7 out of 12% for men, 20 to 25% women. Now, in patients with chronic pain, this incidence is doubled. Why? We're not quite sure. Again, do you develop, severe depression or increase in depressive factors because you have chronic pain, because it affects you over time? Or, do you have elements of pain or depression or major depression already, and your chronic pain becomes inflamed by your depression? It can work both ways. But interestingly, major depression, chronic pain, you're going to find the incidence double over the general population. I just wanted to throw one of our technical terms out there. Number needed to treat. You'll see this from time to time when we talk about medications and how effective they are. So NNT, number needed to treat, defined as the average number of patients treated for one to benefit from that treatment. Okay, let's say 3 patients go on gabapentin, okay, a pretty common neuropathic medication we like. On average, about 1 out of 3 is going to have a good result with gabapentin. That's just an example. So when you see number needed to treat, it might be a 3, it might be 2.5, might be a 10. If it's a 10, then you give a medication to 10 people, then basically one person is gonna have relief from that. So it's just one of the little little scientific terms we try to judge how effective something is. So a little bit more antidepressants for pain. Some studies. A 2008 Cochrane review studied 61 randomized controlled trials. So what's a Cochrane review? Cochrane review is based in the UK. It's basically a charity organization, I believe. And what they do is they try to get to organize scientific studies, similar scientific studies, and organize them and basically kind of compress their results. So they'll take, like 61 randomized controlled trials, 61 different trials of antidepressants for pain, and they'll just kind of process all the information. They'll come up with the general results. And they do that for all kinds of different studies, from all kinds of different journals they'll pull. So out of this review, 17 studies show that tricyclic antidepressants, once again, your norepinephrine, amitriptyline, ziframine, etc., were effective for neuropathic pain. Number needed to treat was 3.6 for at least moderate pain relief, so moderate and better. So every 4th patient really had some good pain relief from tricyclic antidepressants and this is 17 studies combined. And the bottom 3 studies that show the Effexor is much easier to say, which is an SNRI. We'll come to those in a little bit here. Was effective as well. Number needed to treat 3.1, again for at least moderate pain relief. So once again, one out of every 3, a little bit better, and at least moderate pain relief with Effexor, which is another class of antidepressants. So why do these work for pain? I know this slide's a little bit busy.
I just kind of wanted to, grab this off the internet. I just kind of wanted to show where we think and where some studies have shown where these medications help in pain relief. So as you can see, you have, once again, you got your trauma. The red is the signal, pain signal going up to the brain, where your brain feels pain. Then the corresponding pathway back down, where you actually feel the pain peripherally, is the descending path there. And at all these different areas where we think that different medications, God bless you, help. So the tricyclic antidepressants, SSRI, opioids here about the dorsal horn of the spinal cord. Okay, you've got some other medications working in some other areas. You got your local anesthetics, kind of local, working at the skin level, right? You inject lidocaine to the hurt area to numb it up, right? So that's the same thing, local anesthetic, that's where it helps there. Anti-inflammatory drugs, your NSAIDs, your Advil, whatnot. Aspirin, also effective the most at the periphery, at the site of the trauma where the inflammation is going to happen. Anticonvulsants, gabapentin, etc., for the anterior horn there, as you can see. So just kind of a general picture of where we think some of these medications work. This is probably the last kind of busy figure slide that I put up here, but modulation, just expanding on, as you can see, so the ascending pathway red up to the brain, the descending pathway is green, the pain signal coming back down. So we call modulation. You can have signals heading back down to the site of injury, which either suppress pain, block pain, or excitatory. They're going to aggravate the pain, make it worse. And you have, all along the way, you have chemicals in your body that are affecting both of those. You have your chemicals that are going to help block pain, and chemicals that are going to make the pain worse. Called modulation. Norepinephrine is one of these chemicals in your body. Norepinephrine, you probably know that as noradrenaline. You increase your blood pressure, heart beats fast. You fight or flight, right? Run away or fight, or increases a lot of your body's functions. This is a chemical that functions in the brain and the body as a hormone. That's what we know it as usually as, like I said, increasing your heart rate, blood pressure, fight or flight, and a neurotransmitter. Now, norepinephrine is important in the fact that it inhibits these excitatory pain pathways. So it's going to block the chemicals that are traveling back down the spinal cord, making your pain worse. Okay? It's an inhibitor. It's blocking it. Norepinephrine in the central nervous system. This is all I want you to look at. Just this here. And this is happening at your nerve, where the nerve is coming down and the spinal cord and synapsing with your secondary nerve, which is going to basically back to your limb or whatever's hurt. The norepinephrine, let's find it, gray. So it's over here. Okay, these two here. Norepinephrine is going to be released. Going to attach onto the gray postsynaptic membrane here. So, and serotonin 2 blue, that does the same thing. It's an inhibitor. All these other ones, most of these are excitatory. They're going to increase your pain. So what, I put this up here, not to confuse anybody or make someone go colorblind. Basically, I want to illustrate that these antidepressant medications are increasing the time period that norepinephrine and chemicals like serotonin are going to stay active in this area before they bind, and even after they bind. They're going to keep them there longer to inhibit these other neurotransmitters, these other chemicals that are coming down. Does that make sense? Somewhat. So think of it as two people trying to get out the same door at the same time. Okay, you've got kind of norepinephrine on this side trying to get out the door, and you have glutamate
substance P, these excitatory, you get the other side is trying to get out the door as well. Whoever gets outside the door first is going to win. So norepinephrine, these medications, these antidepressants, are helping norepinephrine stay in this area longer and win that battle to get to their receptors and to inhibit the other chemicals from causing their effects. Think of it as two people trying to get out the same door at the same time. If norepinephrine gets out first, you're not going to have much pain. If glutamate substance P get out first, you're going to have pain. You're going to have more pain. So antidepressants and pain, here we come back. So tricyclic antidepressant medications that we've been talking about a little bit before we saw the studies, the way they work, they're decreasing the reuptake of norepinephrine and serotonin, increasing the life of these two neurotransmitters, once again, at that cleft. So tricyclic antidepressants, serotonin, norepinephrine, in the gray, they're hanging out here. Those medications are keeping those drugs, they're giving them a longer half-life, they're making their lives, they're extending them in order to block the pain transmitters. So let's go to tricyclic antidepressant medications and side effects just for just a few moments. Obviously, every medication has side effects, right? And tricyclics are no different. Now, on the right side of the column there, you're going to see some of the common TCAs listed. And in general, as you start amitriptyline and go backwards, you're going to have less adverse or side effects. And typically, that corresponds with how long those medications have been around. So amitriptyline was the first tricyclic. It's going to have the most adverse effects. As we've gotten better at researching these medications and coming out with newer ones, each new one is going to have less and less adverse effects. So amitriptyline is different. On the other side, I just list some of the common side effects. Blurred vision, constipation. I'm sorry, I thought someone's hand go up for a second. Sedation, sexual dysfunction, orthostatic hypotension. You're lying down, you quickly get up, you feel dizzy, your body, your blood pressure hasn't corresponded yet to you getting up quickly. That can be an effect of the tricyclic. So you get up real quick, you're dizzy, you have a headache, you almost feel like you're going to black out for a minute. You got to sit down and just wait until kind of your body adjusts to your new posture. Urinary retention, sexual dysfunction, tachycardia. So another interesting class of antidepressants, which we also use for pain, are SNRIs, short for serotonin, norepinephrine reuptake inhibitors. Two of those are Effexor and Cymbalta duloxetine. Okay, so as you may remember from one of the previous slides, the TCA doesn't do the same thing, right? They're increasing the half-lives of both norepinephrine and serotonin. Why we call them SNRIs as well. Well, TCAs also have some other effects on some of the other chemicals. These are real specific for just serotonin and norepinephrine, hence SNRI. So yeah, Cymbalta is a medication that we really, really like in clinic. It's actually the only medication FDA approved for both pain and psychological conditions. It increases norepinephrine at the nerve junction, just like we've been talking about, two people trying to get out the same door. It inhibits the excitatory chemicals that want to cause you pain, that make your pain worse. Glutamate, that's one of the big ones. Substance P, the way I remember substance P, what it does, substance P, pain, causes pain, substance P. That's one of the ways, that's how I like to remember it. So Cymbalta, the way it works, by increasing norepinephrine at basically at the nerve junction,
It's blocking those chemicals. It's inhibiting the excitatory chemicals. It decreases pain. It's 5:40 already? Oh my God. Am I talking too much? Now, medications are great, but that's if you've been to our clinic, you know we like multimodal, multidisciplinary methods of treating pain. All right, we have our medications, you know, big armamentarium medications, injections, interventions. We love poking people with needles and trying to make their pain go away, right? We also are big on physical therapy. Physical therapy is huge in chronic pain. I didn't have any idea how important physical therapy was. You know, you heard something, you got pain 6 months, a year later, you're afraid to move it because I can't move it. You know, it's going to make things worse. No, you got to move it. Physical therapy. You got to start slow and ramp that up, or else you're going to lose that limb. It's going to be frozen. Physical therapy is so important, and kind of the fourth main part is pain psychology. And you know, you think psychology or psychiatry. First thing, some people may think of Sigmund Freud, right? You know, doctor, I just told you I have pain. Why do you want me to see a psychiatrist? I mean, you know, I'm having pain over here. I'm not crazy. I have nothing to do with it. So anyway, and you're not gonna, if you come to our clinic, you're not gonna see this guy too. You actually may see somebody like David there, who's great. So anyway, I just wanted to talk about pain psychology for a few minutes. We're in the last 25% here, so hang with me. Pain psychology. 18 to 85% of patients with chronic pain have a comorbid psychiatric condition. Okay, and there's the reference there. 35% with chronic back and neck pain have depression or anxiety, going back to what we talked about before. You know, are they causal of each other? Is one causing the other? And which is causing which? Or if you get one or the other, is it affecting your brain so much that it affects the other? You know, you get chronic pain. As we saw, it's all chemically related. It's all, a lot of it's happening in your brain. Chronic pain is going to eventually, one way or the other, is a high incidence of causing psychological factors as well. There's a huge correlation between severity of pain and degree of depression. Another study there from 1997. Pain psychology, cognitive approaches, including cognitive behavioral therapy, biofeedback, hypnosis. Cognitive behavioral therapy, you've been to our clinic, you've probably heard that. Biofeedback. I can't give you an in-depth definition of what that entails, but I know it's very, very helpful with chronic pain. These are all methods designed to help lower your chronic pain. How does it help? Okay, so you have pain, right? What happens when you have pain? You're going to do less. You're going to sit at home. You're going to, you don't want to hurt that part that's in pain. You're going to socialize less. You're going to have less enjoyment. What's that going to do? It's going to increase your stress. God, this stinks. I can't do things I like to do. I'm at home. I'm by myself. You're going to get upset. Which leads to then what? Low mood, depression, anger, frustration. Okay? Which in turn is going to interfere with how you're able to manage your pain. It can actually make your pain worse. The cycles and cycles and cycles, increased depression, increased anger, frustration, decreased ability to manage your pain. This is where pain psychology comes in. Okay, and down here, starting here. You learn tools on how to deal with pain. You learn tools that decrease your stress. You learn methods on decreasing your symptoms. I'm going to work around this pain. I'm going to, whether it be deep breathing, whether it be cognitive behavioral therapy, biofeedback, you're going to break that cycle. And I've tried to kind of keep this as a theme throughout this talk here. Chronic pain is related to your brain. There's no two ways about it. It's all the same chemicals. All the same chemicals in your brain. It's the same chemicals are traveling down and they're affecting the pain. All related.
It affects your behavior, health, emotions, depression, all kinds of different factors. It affects your social life. It affects your wellness, your mind. Psychology. Psychology is the key to all that, to helping to treat some of those big red words there, and with an endpoint of helping decrease your pain, helping alleviate your stress, learning how to cope and deal with chronic pain, which is important. I like to use this example too. Our clinic, it's a pain management clinic, right? It's not a pain cure clinic, unfortunately. One of the ways we manage is with not just injections or meds or physical therapy, but psychology as well. Learning ways of dealing with it. Learning, things you wouldn't have thought about. Oh, you know what? I never thought of that. I'm going to try that. And even if psychology by itself gets you 10%, 15% pain relief, combine that with everything else. Combine that with the meds. Combine that with the injections. Combine that with physical therapy. It all adds up. Very important. So you come see our pain psychology. We're not just going to lie on the couch and ask you about your relationship with your mom or dad. This is different. Okay, and then just to kind of illustrate my point, just kind of going back to the kind of that cycle there. Psychology helps you go right. You're going to go to the right side of the cartoon here. Here we have pain. Without pain psychology, with tools, you're going to probably, we're all probably going to go this way first, catastrophizing, where you kind of believe, and correct me if I'm wrong, David, catastrophizing, you're believing that your pain is worse than it really is. There's something terrible causing this pain, and I'm petrified by it, I'm anxious. Unacceptable pain, uncontrollable pain, tension, fear avoidance. You're fearful, you're avoiding not only physical activities, but social activities because you're scared. You're scared of what, my pain's going to get worse, I don't want to have a flare-up. Anxiety, depression. Pain psychology helps you go this way. Okay. Controllable pain, acceptable pain. My pain's a 3, and I can function on a 3. I wish it was a 0, but it's not. But it's better than a 6 or 7. Normalization, normalizing back to your function, back to a level of activity that you enjoy. Gradual exposure to the activities you want to enjoy. Don't go out and run a marathon the first day. You know what? I used to walk 5 miles. I'm gonna start with a half mile and see how I do. Next week I'm gonna go up to a mile. Gradually work. You know what? I heard a little bit too much this week. I'm gonna stay at a mile for another week, and I'm gonna go up more. Getting back, and finally normalizing. Finally getting normalized with living with chronic pain. Getting back to your activities. Okay, remember, psychology of pain, normal reactions that happen to all of us. Unless unless you've had a lot of training already, we're all going to go left. With pain. I don't know what's wrong with me. My arm still hurts. It must be something terrible. I'm afraid to do anything. Pain psychology. Or a pain psychologist is going to help you go the other way and help you deal with chronic pain, help you get back to who you are. And I've sat in on some of the psychology evaluations, and very, very helpful. So we're almost wrapped up here. How to beat chronic pain? Like we talked about, physical therapy. Not like acute pain. You don't want to rest that limb and let it heal. You want to move it. You want to, you see, a football player tears his knee up. He has knee surgery. Is he laid up in bed for 2 months or 2 weeks? No, he's back out there a few days later. On the bicycle, or in the hot tub. Getting therapy, moving it. You don't want scar tissue to form. You don't want to lose that limb. Some other things here: Tai Chi, yoga. Activities are designed to lower your stress, right? Lower your stress, increase your flexibility and strength. Sleep hygiene, we talked about that.
your body's best chance each day to take the opportunity to heal itself. Got to have good sleep. Those are some other tools of how to sleep better that, you know, such as pain psychologist can help you with. Social support, you know, your friends, your family, you know, going out and doing stuff with people you love, and you know, making you forget about your pain for a little bit. You know what? My pain's from a 6 to a 5 when I'm with my friends. You know, that's good. That's something. So get out there. You know, do your favorite activities. You know, start slow. One of our mottos in clinic: start low and go slow. Start with the smallest activity that you know that you enjoy doing. You know, if you like playing guitar, you know, but you know you have shoulder pain. You know what? You know, I've been doing physical therapy. I feel pretty good, but I'm not going to play for an hour. I'm going to play for 15 minutes. I'm going to see how I feel tomorrow. Start low, ramp up slow. You know, by the end of the month, I want to be able to play for an hour if all things go well. So remember, baby steps. Start low, go slow. Everything begins with baby steps. Journey to 1,000 miles. Once again, What About Bob? Great movie. Great movie. Here are some of the references if anyone's interested. Basically, there's a couple big review articles, and then the Essentials of Pain Medicine textbook there at the bottom. Basically, pretty much what I used here for this talk. And in the end, I'm a big Beatles fan, so I had to get them in. So, the end. Hope everybody learned a little something, and I had fun talking to you guys. So, thank you for being here. We hit stop or
Yeah.
stop share?
Okay.